My name is Peter Beresford. I'm a professor of citizen participation at the University of Essex. I've also got a background working for a long time at Brunel University, London, where I was a professor of social policy. So the disciplines I come from really are sociology and social policy, also with a background in history. So I've always had an interest in how things got to where they are to make a better understanding of where we might be going. I've written very widely on these subjects: citizen involvement, citizen participation, user involvement, and published a number of books. And always the questions that concern me, I think, in the books are the same ones. How can people have more equal access to having a say over their lives when it doesn't generally necessarily work like that? And how might we make policies more fitting for what people want and what's going to be really helpful for them? And then the other critical thing in this is, how can we make it so that the people who work in those services and policies can be supported to do the best job with service users that they want to do? After the war, when unexpectedly a Labour government came to power, they were determined to go with the commitments they'd always made to making life more secure, more healthy, better for most people living in Britain. And absolutely underpinning that idea of the welfare state was the National Health Service. And I think they saw the National Health Service as an embracing policy that would not only make it possible for people to live better and more healthy lives, but make it less necessary to have some of the other things that had operated in the past, where people were poor, badly housed, and often, as a result, unhealthy. That meant that they focused very much on health, and they thought much less about what we now talk of as social care. So you can actually see a distinction arising. The NHS, and Aneurin Bevan was very committed to this, was a central government commitment so that there wouldn't be differences locally according to how different local authorities felt or their politics. It was something to give everybody decent health. And what's critical about the NHS, and still in people's minds, their assumptions about the NHS, is it's a universal service. It's for everybody. It's not about how much money you've got. It's for everybody, rich or poor. That you pay for it in the general run of things in your taxes, so you don't pay for it when you get it. Now, we know there are departures from that, for example, in dentistry, for example, in prescriptions, but that's still what people think. They know here, you break your leg, you have an illness, you need an operation, and you go and you get it. Now, that's not how it's been clearly over the years with social care. To start with, as I'm trying to suggest, social care was really seen as part of the NHS. But over the years, that's kind of changed. And it changed particularly, I think, because of the time of Mrs. Thatcher. Mrs. Thatcher drew a very clear distinction in her mind between social care and the NHS. Maybe it was that she saw the NHS eventually going in the same direction. But the changes that she made through the National Health Service and Community Care legislation, which followed from her, was to make it that people would now probably be paying for social care, that also social care would largely come from the private sector. This was because of those values about the state not being efficient, the state creating dependency, which were held by people like Mrs. Thatcher. So now, increasingly, a division developed, which wasn't originally there, between health and social care. And it's always been a very artificial distinction. And it's a distinction that's particularly unhelpful in the age that we live in, where increasingly, because of the change in our population, and it's a positive change, it means that many groups of people live longer than they might have lived in the past, but might need some support. While we have a population that needs more and more social care, and perhaps less of the traditional, more acute provision that the NHS is associated with, we have a system that's divided where the NHS is still essentially free at the point of delivery, and you pay for it out of your general taxes. You have an entitlement. But social care is something very, very different. Social care is essentially still based on the principles of the poor law that the welfare state was set up to replace. That means you only qualify for free social care support if there are two things going. One, that you can't, as it's seen by the system, pay for it yourself. You are too poor to pay for it yourself. And two, that your needs are seen to qualify for such support. And while we don't ever expect that someone will go to a hospital and they'll say, "Your broken leg," no, I don't think that's going to qualify. There are needs which will be seen as suitable needs for social care, but which will not qualify because of the way the system works. And that's because there's an essential contradiction in the modern English system of social care, which is reflected in some other of the UK countries. That is, it has to do two things at the same time. It has to operate as a policy within a budget, an overall budget, and it is supposed to respond to people's needs according to meeting their well-being, or, as has been the case and has been talked about, in terms of their eligibility. Trouble is, if there's less and less money, then what counts as a need to be met becomes more and more difficult to show. So that needs that might in the past qualify as social care needs do not necessarily now. So, for example, over this period of this year, Age UK has argued that now more than 1 million people who should be receiving social care support are not, because the lines have been pulled back as the budgets have been cut back by central government. The big problem that's raised about social care nowadays is, I think, the problem seen of demographic change. And let's be real about this. It's not seen as an opportunity. It's presented always as a problem. And the problem tends to be presented in terms of the difficulty of there being a mushrooming number of older and very old people who will be a burden on social care. And how will we ever deal with it? And so people are always looking for ways in which more money can be generated, particularly from outside the state, to meet what's seen as a rising cost. This, of course, is basing your whole understanding of social care as a policy in terms of it being about burdens, people being burdens. The thing is that it's a lot more complicated than that. For years now, ever since people started to use those gross expressions like time bomb and burden of age, others have said, show me the evidence base for this. It is actually much more complicated than that. We know that some older people, and not necessarily very old older people, are more likely to have difficulties with their health, which may require them to have social care support earlier. But this is to do with inherited problems of inequality related to health difference. We also know that there are very old people who may have minimal needs for support. It is complex. What we can say, as Dilnot, who did the review of funding for social care, said, is that if things go wrong for you and you have big social care needs, it can cost a lot more than you might ever be able to pay personally. But that's not how it is for everybody. And we also know that if you want to make it that you reduce the risk of health difficulties for older and very old people, there are a whole lot of things you can do, both social and health-wise, to make that possible. We're not talking here about irredeemable problems. The evidence base is limited, suggesting it's so. But there's another point I would want to make. There is a tendency in social care always to see the population we're talking about as older people, and then to talk about the burden of aging. Actually, social care is not only a policy that's there for older people. It is a policy that's there for children, for newborns who may have impairments. It's a policy that's there for people with learning difficulties of all ages. It's a policy that's there for parents who have disabled children or disabled people who become parents. It's a policy for people who are disabled or become disabled in their life. And what we know about all these different groups of people who are people who qualify for support, who need support to live their life to the full, is that all those numbers have been rising. It's not just the numbers of older people and very old people that are rising. All those numbers are rising. Now, you might choose to see that as a problem. You might choose, on the other hand, to see it as meaning that who we are in Western societies is changing. You might want to think about it in relation to other situations of change, like the way in which we've come to see the arrival and the numbers of people from black and minority ethnic communities who make up our population as different from 50 years ago. That, fortunately, is no longer being seen crudely as a problem. Why do we see it as a problem? That the makeup of our society is different, and that some stereotype of able-bodied person is no longer necessarily who we are. We are changing, and it's a great blessing. We are changing because of health advances, which mean that people don't die who would have died. We are changing because we are able to live longer, and that is about opportunity and possibility. And you can frame that in terms of the negative. Oh dear, all these people are going to be around who weren't there before. That's a problem. But why? That sounds to me like something harking back to a very unfortunate idea of who should be living in a society and who shouldn't. I think we need to remind ourselves that we are changing, and that given modern economics, modern artificial intelligence, modern computerization and automation, it isn't a problem if people contribute in different ways and work in different ways. And none of those sorts of characteristics mean that people have to be seen as a cost, a liability, and dependent. And that's the worrying model that I think still lurks in a number of our politicians' heads. I have to say, speaking as someone with grandchildren, I wonder where our economy would be if we did not have grandparents at the moment providing childcare in a society which doesn't seem to want to take on the realities of family life and of work-life balance. And you can go on and on and on in that way with a more sophisticated understanding which we need to get about who we are, the help we might need, and how we, all of us, whatever our age, whatever an impairment may be, can contribute and be part of a changed kind of society, a much more inclusive and diverse society. I've always believed that if we want services and support to work best, then the people that those services and support are for need to be central in the process. They need to be saying what will work for them. We need to be listening to them. It's at least a partnership, and in another way, basically, it's most sensible to put the service user first and to find out what's really helpful. We have a history in societies like ours of making the wrong kind of provision because nobody was listening at the time to what people were saying would be really helpful. We've had that in the history of high-rise housing, local authority high-rise housing, where people were saying they didn't want that. It was built and it was a disaster for many, many people, and its ramifications continue. People need to have a say, and I think arguments for things like personalisation, what I would call person-centred support, have always been based on this sense that people themselves should have a say in the kind of support that they want, that's the way to avoid white elephants and have cost-effective support. But there's also been, in the last number of years, a different pressure coming from a different kind of politics. We live in an age of great change and uncertainty, and we know that there is a powerful political force in our country which is towards privatisation, towards the market, towards expecting people to buy everything rather than to receive it as an entitlement, as was a principle of the welfare state. And that's an ideological point of view. The trouble is that people tend to use the same words coming from very different ideological points of view. So when disabled people, for example, started to talk about direct payments and person-centred support, what they meant by that was that a disabled person, instead of being at the mercy of when someone would come in to get them up, or living in an institution where they had to go to bed early, where they couldn't live an ordinary life, that disabled people should instead have the chance to control their own life. That with a direct payment, for example, they could be the arbiter of what support they got by recruiting someone to work with them who could act as their arms and legs and help them live a life to the full, as equally as possible with non-disabled people. Unfortunately, that's not really been the thrust of what's come to be called personalisation, the personal budgets policy that we've had over the last few years, particularly in England. And that's been something very different. That, at a time of reducing expenditure on social care, and it's always been touted as a way of squaring the magic circle of getting better for less, which I think any of us would always be very wary of. That says, give people a personal budget, and then they will have more control. But what that's actually often worked out to mean is you simply translate what support they've been getting into a nominal sum, and then they get the same stuff, but it's called something different. But also it's likely to be operating at a time of shortage, so fewer people are getting less money. Just because you call something a personal budget, or you say someone's receiving a direct payment, does not make it empowering if essentially it's just a disguise for what you've always had. You get the same old services, or if the amount of money that you have as your direct payment is reduced so that what you can purchase with it is less and less. And that has been a rising problem in social care. A group of us were very fortunate, a group of us including workers, service users and carers. We were really fortunate. We secured funding from the Joseph Rowntree Foundation to undertake a really big project, which extended over 20 different areas with 12 sites for development, where what we were trying to look at is what would person-centred support look like to the people most concerned with it, service users, carers and frontline practitioners. What barriers are there in the way of it, and how can we overcome those barriers? And there was a remarkable consensus amongst those people about what really would help. Two big obstacles that we saw in the way of it. It wasn't just the one, and things have got worse with a lack of funding for social care, but the other was about cultural change, that the social care system that we were encountering in the UK was one that was still very institutionalised. Not only institutionalised that people tended more often perhaps than was necessary to go to institutions, but even living a life that was more institutionalised in their own home. What we began to realise from carrying out this project was how marginalised workers and service users, but let's just focus for a minute on workers, tend to be in the UK social care system. So this was a development project where we were working in sites where we had some resource to input locally. I can remember us encountering in one site workers who'd been on a full shift the night before, who then came to a training session we put on the next day. And I'm not talking here about professional workers, I'm talking about the people that are called care assistants, the people that in our society are increasingly working at or below a minimum wage, where there were concerns expressed by authorities when there was talk of them having a living wage that would make the system unworkable, who are working in a way that's really difficult, where they may only be able to do 15-minute slots, where they're not getting paid for the time it takes to get from A to B, where there is no resource for supervision and the rest. What we encountered was an unbelievable level of commitment and enthusiasm. And I want to say something really important, that if there was one kind of headline that came out of that project, and it was a really positive project, it was that whatever was good about the social care system was the people who worked in it. And the key problems in the social care system we were encountering was the structure of the system itself. And the two, of course, are rather at odds with each other. And this issue of seeing social care as something to sort of put in when people can't do things, like trying either to reduce their dependency or handle it as best as possible, I think has been the model that's underpinned our understanding of social care. It's a word that most ordinary people still don't really understand. People don't get the policy. They don't realise it's not like the NHS. It's something far away from most people until they have to access it. And it is seen really as something that's at the kind of dependency end of public activities, of public provision, at the heavy end, with some people who are sometimes seen as more difficult, mental health service users, sometimes people on the autistic spectrum, and so on. seen as problematic, people with dementia, things we'd rather perhaps not want to know about. And it strikes me this is absolutely looking through the telescope the wrong end. I used to say, when I was beginning to get really familiar with the kind of work that was involved in social care isn't rocket science. It's much more complicated than that. Because it is. What are we talking about with social care? We're talking about working with people in difficulty, at difficult times of their life, facing crises, facing things that mean that they can't be the person they've been before. We're talking about people with life-limiting conditions, people who acquire impairments or who've had impairments, people who may have barriers in the way of their relationships, doing the things they want to do. Supporting people in those difficult human situations is hardly going to be easy, and that's the day-to-day business, not only of professionals like social workers or occupational therapists, but of every care assistant, like the many we've met, who takes their job seriously, trying to do the best they can to help people in difficult circumstances where we don't live in a world that necessarily values either their work or those people in that situation. And that means, why have we got a mindset that means that we have one notion of reward for people within the NHS and can value and respect their contribution because we can see them in terms of uniforms, health, machines, programs on telly, and a different one altogether, which is all based on marginalisation for people working and doing their best in social care. We must challenge the way that workforce is seen. We must make it so it's not a workforce that the only people who will go into it are those who feel they have very little choice, those who come from migrant populations, those who've been marginalised. And it's not going to be tenable, because we already know that people who've got less occupational opportunity still will more likely now go into supermarket work than they will go into social care work. So why can't we give it the value that it should have? Because it's helping people with the most complex issues, sometimes at the most complicated times of their life. That's something that, for me, is really valuable if we think of ourselves as an inclusive and civilized society. But it's also obviously something that's difficult, and we should be thinking about it in that sort of way. I don't think our policymakers have yet come round to that way of thinking, yet, as I would argue, there are going to be more and more of us who need that support. If we had started in 1948 with a notion, 45, that we can't have an NHS because it would be so wasteful and costly, it's very difficult to see a policy currently that is as wasteful as social care. Its impact on our NHS, we know, is wasteful in terms of cost, wasteful in terms of human misery, in terms of what's called crudely, I think, bed blocking, in terms of constant readmissions to hospital, because people do not have the support they need with longer term conditions. People need social care support. When are our policymakers going to wake up to the fact that that is the future, and it's an economically viable future? Not only is it an economically viable future, but it's a creative future economically. There will be new opportunities for us, and I think we can be pioneers in this, and these are ideas even that we can export in a good way to other societies. When I've been a board member of Skills for Care in England, obviously one of our concerns has been to find out how to improve the workforce, the kinds of difficulties facing the workforce, the conditions of the workforce, and very, very big surveys are made routinely by Skills for Care. And there is no doubt, although there is always a tendency to aggregate the information from different sectors, that the sectors with the best conditions for workers are the public sector and parts of the charitable sector. Unfortunately, the evidence we have are that conditions in the private sector tend to be the least positive conditions for workers. And I think, especially since over recent years there has been a diminution of resourcing, of funding for social care. So I think we know that it's a struggle in the private sector to make the profit that they're there for, and so I think conditions have not improved. I can remember when I was on a government committee in England concerned with the workforce, although I did try to do it myself, nobody ever said anything, at least of all if a minister was present, about well, hang on a minute, isn't there a basic elephant in this room, the pay and conditions of the workforce? Because people have tended to take it for granted. And if I could just say one last thing in relation to the workforce, I do think the leadership of social care, the formal leadership, needs to be a lot more assertive, both for service users and for service workers, more demanding. We are operating, everyone, including ministers, has said it, we're operating at crisis times for social care. It is in a very bad state. It cannot go on. The government has said it's going to produce a green paper, but we don't know what that will mean. They've offered in this last budget some very small amount of additional money for social care, whereas almost all the money that they've put in from what they said is the ending of austerity has gone to the NHS. That same inequality operates. So long as we can see social care as a marginal policy that's needs and means tested for somebody out there, rather than at last realising it's increasingly for all of us, so it's going to be. And it will not work, and it'll be more and more damaging. Some of the roads that have been gone down in England, which we can see, I think, as false roads, are roads it would be very helpful for people in Northern Ireland to think about trying to avoid. And I think a key road to try and avoid is the idea of paying for social care. The populations who use social care, whatever some policymakers or ideologues might think, are populations that generally want to be independent, don't want to take, but rather want to give. So the assumption that they are trying to rip off the system, steal benefits, or get support they don't need, I think is a fallacious one. We don't need to put barriers in the way of groups either that need help. And there's no question that charging is a barrier. Also, it would be good to see more to show the financial benefits of such charging, which I suspect are very little, if any. It costs, it has its own implications for organising a policy, for paying for a policy, to make all that work. It's not something that's free. So let's look very carefully. Social care was beginning to work better in England, I'm not saying ideally, before the shift to the idea of charging came and of payment from the Thatcher government onwards. So I'd be very wary of that.